There is no golden exercise for pain, but exercise itself can change the way you experience it. Let's talk about it.
In this video series, I'll show you how you can make your pain go from this to this by changing 7 different variables. Quick disclaimer, this video is not meant to be used as a substitute for medical advice. If you have a serious problem or serious issue, please visit your local medical care provider. In less severe cases, you can always use my free resources or my one-on-one online health coaching at varita.com. I hope you enjoy. Later in this video, we'll do a deep dive into why exercise is so important and how you can implement exercise for pain. But first, we need to look at what doesn't work and what is often propagated on social media and by different clinicians as well. The sexy quick fixes, the things that are supposed to be the solution to your problems, to all your problems, and we'll see why that's not true, why we need to stop focusing on the specifics of things, and why there's no golden exercise for pain, and exercise in general is so valuable. People will often say on social media, your back is stuck, you need to open it up, or your body is stuck, we need to fix it, we need to fix something about your body for the pain to go away. There's a problem with your joint, there's a problem with your knee, your back, something else, and it needs to be fixed. But the thing you need to wrap your head around is that we're all a little bit fucked up. We're all a little bit misaligned. With all of us, there's something a little bit uneven, not right. And later in the video, we'll look at proof and evidence that it goes even further than just misalignment, but actual structural damage that many people have without having any pain, without having any problems. With me, for example, my left shoulder is oftentimes higher than my right shoulder. My feet are as flat as they can be. My knees are often a little bit rotated inward, a little bit caving in, but I'm not experiencing any pain. And this, of course, is just an anecdote, my story. But just to show we don't have to be perfect, we are not perfect. And even if there were these like highly specific exercises, specific interventions, how specific are they? Like doing a shoulder press versus like a external rotation with a cable, like how specific is that? Like, do you want to go upside down handstand while lifting a dumbbell and having a finger up your ass or something? Like how more specific you want to make these exercises. We're humans, we're not doing surgery on ourselves. We're influencing the body from the outside. There's only so much that you can do. These specific exercises are not going to change your body structure in any significant ways other than other exercises would do as well. Just like manual therapy, chiropractic adjustments and realignment are not going to really change or reshape the structures of your body. They're not going to fix you, they're not going to open something up. If you've ever seen a surgical room and seen how an operation on, for example, the knee joint is performed, you'll see how much force, brute force, they'll literally start hammering things inside your knee to try and move things, to try and get through bone or ligaments or whatever it is. You need to understand the body's really strong structurally. And if you want to make any significant changes to that structure, you would either need like severe trauma from an accident or whatever, or like surgery, but doing a manual adjustment, a chiropractic adjustment, it's not going to change anything significant. It's just not. And we'll talk about why that is and what you can expect from these treatments and interventions. These treatments and quick fixes are too much on the forefront of health and science and exercise right now on social media, and it's just so much noise.
2 exercises that you need.
Let's first look at what science has to say about manual therapy, manual therapeutic interventions, hands-on interventions, right? So something that chiropractors might also do, really touching the body, adjusting the body, hands-on treatments, as you might call them. As early as in 2010, they already came out with a study that tried to differentiate whether manual therapy interventions were effective due to their high specificity and application of joint-biased, tissue-biased, nerve-biased manual therapy are different than related neurophysiological responses, are similar and adequately encompassed within the model given the current state of knowledge. It says as follows: biomechanical effects are associated with manual manual therapy, as motion has been quantified with joint-biased manual therapy and nerve-biased manual therapy. However, the direct implication on clinical outcomes is questionable. First, only transient biomechanical effects, so short-term effects, are supported by studies which quantify motion, but not a lasting positioning change, right? So they're saying there's no real structural change that lasts over a longer period of time. It's only in the moment itself that there might be some biomechanical changes. Additionally, different kinetic parameters are observed between clinicians in the performance of the same technique. And the choice of technique does not seem to matter as much as identifying individual likely to respond. All right, so what they're saying here is different therapists will use different techniques and different parameters of pressure, different points of pressure, different amounts of force. And on top of that, it doesn't really seem to change the effect of the intervention, so it's not very specific. And on top of that, figuring out might respond well to a treatment like this is more valuable. So someone that might strongly believe in this kind of interventions, or a patient that might explicitly express the feeling of being stuck, maybe it could have more benefit. Finally, studies have reported improvements in signs and symptoms away from the site of application, such as treating cervical pain with manual therapy directed to the thoracic spine, and lateral epicondylitis with manual therapy directed to the cervical spine. Collectively, the literature suggests a biomechanical effect of manual therapy. However, lasting structural changes have not been identified. Right? So the idea of like fixing your body, changing the structure of your body, there's no real ground for it. Not logically and not scientifically. Furthermore, it doesn't seem to be a very specific treatment. So if you'll hear on social media, like, you need to do this in this very specific way, and we need to adjust your body in this way, know that it's probably not going to be that specific. It's not going to change your body structure. And on top of that, this study shows that you might actually have beneficial effects from an intervention to the body, like adjustment or a twist or whatever, to a different part of the body. They said from the thoracic spine, right? From the mid-back, it had effect on the cervical area, just like adjustments on the cervical area had effects on the thoracic spine. It further reads, the mechanisms behind the clinical effectiveness of manual therapy are not established. Limitations of prior mechanistic studies are the study of individual mechanisms without regard for others and the failure to adequately account for non-specific effects. We have proposed a comprehensive model. Alright, so they're saying the studies that were done for manual therapy that did show a great biomechanical change did not account for other changes such as neurophysiological changes or other non-specific effects. This other study from 2017 looked at what mechanics were behind the manual therapy. It reads as follows. We have previously proposed a model suggesting that the mechanical force from a manual therapy intervention results in systematic neurophysiological responses leading to pain inhibition. Little has changed to support a mechanism related to specific biomechanical parameters of the interventions since the model was originally published, and in fact, more recent studies continue to refute a specific biomechanical mechanism. So again, to support this idea, don't let people sell you on their incredible precision, incredible specificity of their interventions or techniques, because there doesn't seem to be any evidence for it. Systematic reviews support a transient, short-term, short-lasting, pain inhibitory effect of manual therapy on psychophysical measures occurring both locally and remotely. Higher pain sensitivity as determined by a lower pain threshold at the site of injury or pain may reflect local sensitization in the peripheral, reduced receptor threshold or central nervous system specific somatosensory regions, while higher pain sensitivity at sites distant from the site of injury may reflect more general sensitization of the central nervous system. Changes in pain sensitivity are observed in response to manual therapy both at the site of application and at distal sites, indicating the presence of central mediating effects. The approach of such studies is often limited to assessment of static measures of mechanical and thermal pain thresholds, providing little insights into individual pain modulation capacity. Moving forward, we believe that the traditional emphasis on solely biomechanical mechanisms of manual therapy is misguided in focus and limited in scope. Subsequent efforts should focus on broader understanding of how manual therapy alters processing of nociception to impact the entire pain experience. Specifically, greater consideration of pain modulatory capacity as determined by dynamic measures of psychophysical testing. Consideration of physiological responses to manual therapy and studies better designed to account blah blah blah. Okay. So what does this mean? What are they saying? It's a very robust study saying that the traditional emphasis on solely biomechanical mechanisms for manual therapy is misguided and limited in scope. Now it's important to understand that they don't say manual therapy has no effect or it is useless, but the idea that it's highly specific and it changes the structures of our body is the reason why our pain experience changes is not true, is unfounded, is what they're saying yet again, right? They're saying, okay, there is definitely some kind of effect, definitely a short-lasting effect, but why is this effect there? And they're saying it could be due to central nervous system desensitization, changes in neurophysiological changes, changes to the brain, changes to your nerve, how we receive data, right? How our body receives information, right? What is it receiving? If you slap someone here, nociception, what they mentioned in the paper, nociception, a signal goes towards our brain, how is it processed, etc. That might be influenced by manual therapy, but no structure is being changed. Another living review, a review that is constantly updated and looks at other reviews, also struggles to identify what the core mechanics behind manual therapy are and struggles to find any real substantial ground for structural effects of manual therapy. And this review was last updated in 2025, so it's very up to date. And yet again, if it was as simple as a structural change, we would likely know it by now, right? There are many research papers published around manual therapy and what could be the mechanics behind it. And it definitely leans more into pain modulation, it leans more into neurophysiological changes, temporary pain relief, etc., than actual structural change through biomechanics. So what do they say? Well, they looked at 62 reviews and they state the following. Findings support critically low to moderate quality evidence of complex multi-system mechanistic responses according with the application of manual therapy. Results support peripheral segmental spinal and supraspinal mechanisms occurring with the application of manual therapy, which can be measured directly or indirectly. Clinical value of these findings have not been well established, while manual therapy has proven to be an effective intervention to treat conditions such as pain, current body of literature leaves uncertainty to why manual therapy interventions work, and future research should better define which mechanisms or combinations of mechanisms are mediators of clinical response. Overall, the current review supports peripheral, segmental, spinal, and supraspinal neurological mechanisms occurring with the application of manual therapy, which can be measured directly or indirectly. Manual therapy has been shown to attenuate nociceptive spinal excitability, right? So, like I said before, nociception, the receiving of information from your body towards the brain, the sensitivity of how this is measured, the sensitivity of the information received and retrieved can be adjusted, likely adjusted by manual therapy. This alteration in neural excitability as well as changes in tissue sensitivity as measured via PPT are theorized to occur due to facilitation of descending inhibitory mechanisms. Long story short, they again said that it is likely due to a change in our sensitivity, a change in how we respond to information, and a change in how information is regulated in our body, instead of, oh, my back is stuck, someone needs to yank on it, twist it, turn it, crack it. No, there's just no good evidence that it works, that is a thing, and people need to stop informing the public about stuff like that. Now, why do I put such an emphasis on this? I put an emphasis on this because if people think their pain is highly related to structure, to structural changes, to something being stuck, etc., then it's really difficult to introduce new ways of thinking and to apply new interventions for these people. If we want to help people with pain, which I personally really enjoy doing and love to do, then it's really hard to help them if we think we need very specific interventions, things that are highly specific, like magical solutions that is often propagated online. It will be very hard to understand why these 7 variables that I showed in the beginning of the video can have a drastic impact on the way we experience pain. It's also a call to the professionals in the field that do use manual therapy and hands-on treatments to help clients and patients to be honest and try and be honest with why your techniques work and what we do and do not know about them. And don't make it a structural story, a biomechanical story, because it's going to be very, very difficult for other colleagues to help that client or patient with different types of interventions if all the client thinks and all the client knows from the previous therapist that, oh, there's something stuck in my body, he tried to crack it loose, my back cracked, but it didn't work, so what now? Because my pain is because it's stuck, right? So how could it be that you want me to do meditation? Like, what are you talking about? Like, it's very difficult to convince them as colleagues, so please be honest with why you do certain techniques and why you prefer certain interventions. Okay, that's the manual therapy story. Let's look at structural changes, right? Because that's what I'm kind of hammering down on. That's what I've been mentioning, but what's the support for this? Am I just bullshitting, or is there actual robust support that pain is not necessarily related to structural changes? And honestly, pain is not related to a structure more often than not. It is highly unlikely that your pain is solely, like 100% caused by a structure. Structures can have an impact on your pain experience. I truly believe that. But in most cases, it is not the main reason and often not the thing we have to focus on. So here's some signs we can look at. This paper, for example, showed that in asymptomatic elite tennis players, 33% of them showed spondylolisthesis when scanned, and some of them showing pars fractures as well as stress fractures. Yet they experienced no pain, right? They were asymptomatic, meaning they weren't experiencing any symptoms, they were experiencing no pain. Yet 33% of them showed up on scans with spondylolisthesis. Spondylolisthesis is the displacement of a disc in your vertebrae that kind of shifts out of place. Another study, as you can see on the screen, states the following. 90% of asymptomatic people undergoing cervical MRI scans have a bulging disc. 90% of asymptomatic people undergoing cervical MRI scan have a bulging disc. That is insane to know, right? 90% of people. Disc bulging was frequently observed in asymptomatic subjects, even including people in their 20s. Even people in their 20s, such as me, can have bulging disc on scans without ever having pain. Another study, 1 in 3 people over the age of 30 and 2 out of 3 people over the age of 70 have abnormal MRI findings related to their shoulder, including complete rotator cuff tears, right? So imagine your subscapularis muscle or your infraspinatus muscle or your supraspinatus muscle, whichever rotator cuff muscle it is, completely being gone and not experiencing any pain. After successful rotator cuff surgery and post-operative rehabilitation to regain full range of motion, strength, and function, MRI reports reveal abnormal findings, and 20% still have complete rotator cuff tears. Insane, right? Demolition derby drivers crash over 1,500 times during their careers, averaging over 24 miles per hour, and yet almost all report no chronic whiplash-associated neck pain, right? So structures are not well related to pain. Anyone that sells you or tells you otherwise tells you your body needs to be fixed, your body is broken, there's something wrong with your structures. Ask them how this is possible, and also ask them what else you could do to improve your situation other than them cracking your back, adjusting your back, or whatever it is. Okay, so if hands-on adjustments aren't very specific, and if we know that structural changes don't really mean pain, don't equal pain, then why are there so many specific exercises? And do specific exercises help, even though manual therapy doesn't seem to do that much, structurally at least? Let's have a look. This study in 2016 showed that there is moderate to high quality evidence that motor control exercise provides similar outcomes to manual therapies, low to moderate quality evidence that it provides, here it comes, similar outcomes to other forms of exercise. Right, so first study that we look at, 2016, shows motor control exercises, which is a form of specific exercises for your back, doesn't seem to have a significantly better outcome than general exercises, which is interesting, right? Another study compared from specific neck exercises versus more general exercises. It shows that mind-body, so exercises where you're moving with intent, moving while being very aware of your body's positioning, etc., and aerobic exercises had the same effect on neck pain compared to specific neck exercises, right? So already 2 studies that show general exercises, even aerobic exercises, which is going for walks, a jog, light jog, cycling, can have the same effects as specific neck exercises. Another study looking at rotator cuff related shoulder pain found the following. Motor control exercise programs were probably slightly superior to non-specific exercise programs. However, it is unclear if the effects were due to motor control exercise or to other program characteristics such as progression and tailoring. So you could think of maybe like a regular dumbbell shoulder press, right? Controlled, slow, and progressed over time, versus maybe grabbing a rubber band and pushing it forward while trying to go slowly back, stabilizing it, having the motor control, something like that, or holding a kettlebell while laying down and like trying to stabilize it or whatever. Like these kind of specific exercises versus just a regular dumbbell press showed no real difference. Slight superiority, but they're not sure why. Systematic review from 2025, so super recent, looked at specific exercises for shoulder pain, which found while these targeted exercises offer valuable insights for clinical shoulder rehabilitation prescriptions, so it's nice to know different kind of exercises, they do not show an obvious therapeutic advantage over general exercise or conventional physical therapy, right? So again, a review as recent as 2025, this year, showed the specific exercises don't really matter that much. Just make sure you exercise. Another study looking at adults with subacromial impingement syndrome found no significant difference between specific exercises as general exercises, and they found something interesting, that maybe focusing on decreasing fear of movement might be more valuable than the type of exercise. Right? That's an interesting one, and one to keep in mind. Another study to reference says the following: compared with conventional rehabilitation and no intervention provided, Tai Chi, yoga, Pilates, sling exercises, motor control exercises, core and stabilization exercises significantly improved chronic lower back pain in patients, compared with conventional rehabilitation and no intervention provided. Right, so all these different exercises seemed to have a benefit and improvement in people with chronic lower back pain. How is that possible? We'll come back to that in a second. Why exercise is so valuable and why it doesn't really matter in what way, shape, or form you do it. Maybe a little bit, but in general, it is about going to exercise. Start exercising. That is what is important. And don't let some Jimmy sell you his new exercises, best exercises, new invention, the thing that will fix your body, the thing that will fix your problems. It's just there's no evidence for that, and it's honestly just bullshit. Another meta-analysis did not highlight the superiority of one treatment over the other for mid-portion Achilles tendonitis. Even if we're looking at this study, they looked at real structural changes in the Achilles tendon. From pre to post, there was a significant time effect and a significant time by group interaction effect for the mean Achilles tendon cross-sectional area. Post hoc analysis showed tendon hypertrophy across the whole tendon length for the high-low group from pre to post, right? So there was a clear difference before and after intervention of the thickness of the Achilles tendon. It says, thus, superior structural adaptations such as increased Achilles tendon stiffness and reduced tendon strain did neither directly post-intervention nor 6 months later at follow-up appear to directly translate in a superior reduction in tendinopathy symptoms. Right, they're saying even though the structure changed, even though it got stiffer, even though there was some form of hypertrophy, the pain did not change. So structure, pain again. No correlation, right? It's funny because with Achilles tendons in particular, it has gone through some phases, right? So you first had a phase where people were like, oh, you really have to do isometrics for your Achilles tendon. You need to do isometrics. Then we went into the phase where it was all about eccentrics. For tendinopathy, tendon problems, you can't do any other exercise other than eccentrics, or you're doing it wrong, you're doing it bad, you're a bad therapist if you recommend anything other than eccentrics. Guess what? Years later now, we're doing high-loaded, slow, low reps for Achilles tendinopathy. Seems to work just as fine, but again, it doesn't necessarily matter for pain. Structure might change. It's good for your tendon, but for the pain, it doesn't matter that much. Now, the conclusion of all this together, of all this information. It's a lot of information, I know, but bear with me. The conclusion. You might think, oh, so it all doesn't matter. It all doesn't matter, just do whatever. And in a way, yes, kind of, but not entirely. The essence is that exercise works, and even manual therapy works short term, but not in the reasons many people claim that it works. And the same for exercise. Exercise is really, really, really important, but not because of the program they are selling. It's not because of the special exercise they have, the new way of training your tendons, the new way of training your shoulders. No, exercise works because exercise works. It's just amazing. And we get to the specifics on why it works, the chemicals, the hormonal changes in your body, the increased blood flow, the increased oxygen throughout your body, etc. But for now, know that the problem for most people, almost everyone, when it comes to exercise, it isn't that people don't do the right exercise or don't do exercises. It's that they either don't do exercise or they don't do enough exercise. And there's a whole different challenge to that with motivation and meaning. But a good first step is understanding that there is no magic. You're not doing anything wrong. Don't be afraid of exercise. Like, oh, I need to know the specific one to do it in the perfect way. No such thing. And just try your best. We need to start moving. People need to start moving. Personally, I think it's very liberating to receive information like this, that there's no specific exercise necessarily needed, that manual therapy interventions and chiropractic adjustments, etc., aren't very specific, and that these people always hung up on the biomechanics side of things and saying, oh, you're doing it wrong because it needs to be like this and very specific, and oh, you need to be careful, this and that. I think it's very liberating that that's not the case, and that we can actually focus our energy and our effort in, first of all, starting to exercise. And then, like I said, how do we motivate people? How do we reduce fear? How do we keep it challenging? What are other really important factors to pain? So we have more time instead of focusing only on one thing. What are the other variables? Just like I said in the start of the video, in my opinion, there are 7 big variables we can impact. And let's look at that. How is the diet? How is the sleep? How is the stress? Etc. Another reason why it was really important to start with looking at these examples, how it's not necessarily the structures, it's not some special exercise, some specific exercise or a specific adjustment, etc. Because clinicians, and I've seen it myself many times in practice, will take credit for people becoming pain-free. And that must be really nice to be able to take credit for a patient becoming pain-free. But what happens if a patient doesn't become pain-free? And that's also something I saw a lot. And then they've tried their specific method, their adjustment or their specific exercises for the shoulder or whatever. Patient doesn't get better with pain. And then we're out of options. We tried our specific thing. We don't look broadly. We don't look at other factors, other aspects we can influence. And then it's send the patient home, send the client home. We've tried what we could. We tried our specific thing. And I think that is not doing the patients justice, not doing the clients justice. And it's a little bit naive because more often than not, physiotherapists at least will see a client for, let's say, 6 weeks, right? You'll often hear this. This will be an intervention for 6 weeks, 6 weeks, 6 weeks, 6 weeks. Why 6 weeks? Because time also heals. So that's so important and overlooked. Like, so in 6 weeks, a lot of clients or patients will get better. Honestly, even if you don't touch them or, you know, I'm just going to say like touch their feet or something, even though they have neck pain, they'll improve in 6 weeks because time just heals, right? Yet we still take credit for what happened. And then we don't take responsibility when it doesn't work. And we only look at one thing and not at the whole picture. It's just a little bit meh. And that's why I think it's important to add the mechanics behind pain, add why structure doesn't mean pain, add why damage doesn't mean pain, add there's no magic exercise, no specific exercise, etc. So that we can also hold ourselves accountable for the fact that there's more to humans, there's more to people, and we need to do better, I think. And also because these specific exercises and adjustments and techniques, they give clinicians and other professionals and other gurus, whatever, so much authority over movement and exercise that if you don't do it their way, you're doing it wrong. Or if you don't do it their way, you're not going to be healed or fixed. And they found the way. And it's often used to sell things, right? The specific exercise, the specific adjustment or whatever. That's also at the core, at the root of the problem I'm trying to inform you of and I'm trying to address. Now you might say, okay, but I've been to a manual therapist, I've gotten their intervention, and it worked for me. First of all, great, amazing. I'm glad that it worked for you. But there's a reason why we have science. Science accounts for different variables, different restraints, such as also time, right? And it compares people and tries to see if it's actually applicable to a majority of people or not. And on top of that, like I said, manual therapy can work. It's definitely shown to work short term, but not because of structural change, not because they fixed something, opened up something, made something better structurally. It can help because when you make an adjustment or do something, or even when you have a massage or something like that, the information coming from that region, let's say you have back pain, that information coming from that region might be modulated for a bit. The sensitivity might be reduced for a bit. The nociceptive input might be reduced for a bit. And then you can move with less pain or pain-free for a little bit, maybe a few days, maybe an hour, maybe a few minutes. And then you can actually move more and maybe do some exercises, which in turn will calm down your nervous system, let your body know, oh, actually, it's kind of fine to move. It's not, I'm okay. It's okay. And then everything calms down, your pain gets reduced, etc. That's how I think it can work.
And now we're going to look at how exercise is so beneficial, why it doesn't really matter what exercises you do, why exercise in general is just really good. And after that, we're going to look at how you can implement exercise for acute pain as well as for chronic pain. We're starting with blood flow and increased oxygen. And many of you will already know that exercise will increase the blood circulation throughout the body. When we move, even at low intensity, our muscles require nutrition, require oxygen. This increased demand results in vasodilation, the widening of blood vessels, and an increase in circulation, increase of heart rate. This better circulation doesn't just feed the muscles, it also improves the chemical environment and helps clear out inflammatory metabolites and deliver oxygen to both nerves and connective tissue. The improved perfusion can can lower nociceptive signaling by literally changing the chemical soup. When you move, your blood flow increases, carrying more oxygen to different tissues, including to your nerves. And oxygen isn't just energy, it's a stabilizer for the whole nervous system. Each neuron sits at a resting membrane potential of 70 millivolts, always in the balance between firing or not firing, always on the edge. It can tip either way, with only a small change.
A small change of voltage, about 10 to 15 millivolts, can make it that a nerve never shuts up, never stays quiet, keeps sending nociceptive signals to your brain. When oxygen is limited, neurons become unstable, always ready to fire, always more agitated, easier to signal. Whether from poor circulation, inactivity, or shallow breathing, this can all make the neurons more sensitive. This can all make the nervous system more sensitive and reactive to pain, for example. On the other hand, an increase in oxygen can hyperpolarize the neurons slightly away from the firing point. So instead of tipping towards it without oxygen, if it has a lot of oxygen, it might go a little bit away from the firing point and be less reactive. So when you're moving and breathing heavily, breathing deeply, you're not just fueling your muscle, you're also calming down the nervous system, calming down billions of little electrical systems within your body, which will make pain less likely and calm down the nervous system. Second point, synovial fluids. Joints aren't a static structure. It's a living system that depends on motion to stay healthy. Movement stimulates and contributes the distribution of synovial fluids. When we stop moving, that fluid becomes stagnant and we might start to feel a little bit more stiff, a little bit less smooth. Not because it is damaged, but because the chemistry has changed and the mechanics have changed of the joint. Now, gentle movement can reintroduce the fluid and redistribute the fluid, and it will make the joint feel like it moves more smoothly and nicely. This reduces the friction and mechanical stress within a joint. Now, less friction and less stress from a joint means there's less signals going towards the brain, right? If it's moving more smoothly, less signals being fired from this area towards the brain. And then your brain won't think there's any danger because the amount of signals is it's just a regular amount of signals. If there is no fluid and like you've been sitting for 10 hours straight and you stand up and you might feel a little bit of pain, it's like a lot of signals going through your brain because there's no fluids, it's the mechanics, there's a lot of mechanical stress on it. Number 3, nociceptive reduction through strengthening physiology. Regular exercise trains more than muscle, and our tissues become more conditioned. The same physical loads produce less irritation and less local stress. This means there will be less signals from that area being sent. So if you have a strong leg and you have knee pain, or a weak leg and you have knee pain, if you strengthen that leg, there's a chance that because you strengthened it, there's going to be less pressure on your joint, less pressure in that area, less stress in that area, so less signals are going to be sent to your brain. Number 4, sensitivity reduction through graded exposure. Pain sensitivity is not just about injury, but about how the brain responds to different stimulus. Graded exposure, gradually increasing exercises. For example, if you have shoulder pain, first only moving in this amount of range of motion in this plane, and if that goes okay, go a little bit further. And if that goes okay, go even a little bit further. That's just graded exposure, right? It's just like every time, go a little bit further. And what this does, it helps our body recognize, it helps our nervous system recognize that it's safe. It calms everything down. If you just jump into the water, your system will be shocked and worried and thinks it's not safe. If you slowly build up to it, it could be in days and weeks or months if your pain has been around for a long time, but just know you can move step by step, step by step. Number 5, hormonal production. Exercise triggers a very powerful neuroendocrine cascade. It increases the release of endorphins, endocannabinoids, dopamine, and serotonin, all of which modulate pain and mood. At the same time, consistent training helps regulate cortisol and insulin and balancing our stress and energy system. The result is not only pain relief, but an overall improvement in resilience, mood, and the body's ability to stay in homeostasis. Some of the hormones produced during exercise are endorphins. These are endogenous opioids, natural painkillers produced by your brain and pituitary gland, and they attach to the receptors in the spine and in the brain. They inhibit ascending nociceptive transmission as well as enhanced descending inhibition from the brainstem. It results in the reduced perception of pain, as well as an increased feeling in wellness, commonly referred to as the runner's high. Another hormone produced are endocannabinoids, like amidanide and 2-AG. These molecules act on CB1 and CB2 receptors, influencing both nervous and immune systems. They suppress neurotransmitter release at pain synapses and reduce inflammatory cytokine activity. They also interact with the dopamine and serotonin system. Dopamine and serotonin are other hormones that are produced during exercise. They enhance the brain's descending inhibitory pathways. Another result from exercise is cortisol and insulin regulation. Regular exercise helps regulate cortisol rhythms and improve insulin sensitivity. Let's move on to the function of muscle. Muscles are not there to only move limbs and produce force. They are metabolic organs. During contraction, they release myokines, signaling molecules that influence inflammation, brain function, and the immune system. Strong, active muscle help regulate glucose, mitochondrial function, and oxygen utilization throughout the body. These systematic effects directly influence pain perception by supporting energy balance, tissue recovery, and anti-inflammatory signaling. Function of nerves. Healthy nerves require a steady supply of nutrients and oxygen. Exercise enhances microcirculation to nerve tissue, promoting regeneration and optimal function. It also supports the production of neurotropic factors such as BDNF, which strengthen neural pathways and improve body's pain modulation capacity. Essentially, movement keeps the nervous system young, adaptive, and better equipped to regulate different signals. Our brain requires about 20% of our body's blood circulation, even though our brain is only 2% of our body's weight. It's a small part of our body, but incredibly important. And it requires a lot of oxygen. It requires so much oxygen. Our brain is an incredible powerhouse, and that's why it's also so important to keep it supplied with blood flow, to keep it supplied with oxygen, that you indirectly influence, or maybe you could say directly influence, through things such as exercise. We have so many nerves in our body that if you were to lay them side by side linearly, it would stretch about 70 to 100 kilometers. That's the same distance from Rotterdam to Amsterdam. It's incredible how complex and intricate our nervous system is, and how important it is to keep it well supplied with oxygen. Now let's get down to the nitty-gritty of things. I gave you a lot of information about things that don't work, things that are often overstated and used to give a false impression of how pain works and used to sell you things, etc., as well as how exercise in general can benefit the body and benefit our pain experience. All these benefits that I mentioned don't come from one particular exercise, they come from exercise in general. Doing a good mix of aerobic, so cardiovascular exercise like jogging, running, walking, swimming, cycling, etc., is really good, in combination with some strength training like lifting weights or doing body weighted exercises to really push your muscles. Any combination of these two in different shapes and sizes is great for pain. It's really good, and I highly recommend you doing it. You don't have to look for a specific training protocol, a specific regimen, but like we've seen, the benefits of exercise are incredible, tremendous, and in so many different shapes and sizes, just as there is no specific exercise that is better than another exercise. What to keep in mind when doing exercises, and I would say is really important, is that you keep it safe. Don't make your environment dangerous or unstable or unpredictable. So know where you are, what you're doing. Keep things controlled. It doesn't have to be the perfect technique. It really doesn't have to be. But make sure it's controlled and it's a way you can perform for a couple of repetitions. Make sure it's challenging, right? Especially if you don't experience any pain, it's really good to challenge the body. But even when you're experiencing pain, make sure that you have a combination of exercises that don't hurt at all, if possible. And if you're always in pain, then make sure it's acceptable, that it's in the acceptable range. Don't be afraid of the pain. Don't stay away from it. Also, don't force through it. Flirt with the pain. A general rule of thumb is if you have a scale from 0 to 10 on a pain rating scale, 0 being no pain and 10 being the most horrific pain you can ever imagine, staying under or around the 6, preferably lower if possible, if you can adjust the exercises to be lower, is good. We don't want to go over this 6 because we might re-trigger the central nervous system to sense danger, sense alarm, and then the pain can maybe increase again for a little while. We want to let our body experience that movement is safe. That's the most important part. Let it experience it's okay to move, it's safe to move, and that you do a little bit more and a little bit more every day if possible. How to apply exercise to acute pain. Alright, you just sprained your ankle, what to do next? Don't lay in bed. Don't completely stop moving, okay? It is good to be cautious if you just got an acute injury. First of all, be aware of what is happening to my body. Am I sweating? Am I dizzy? Am I nauseous? What is the structure looking like? Is there bone disfiguration? Did you break something? Did you not break something? Okay. Once that is out of the way, once you know, okay, I don't need a hospital visit, right? But it still hurts like heck because I just sprained my ankle. Then what you do is you stay calm. First of all, you stay calm. That's really important. And you start moving the joint, moving the area that hurts in every single way that is possible without forcing it. You're going to explore what is possible with your ankle. And what you'll notice is certain movements go a little bit easier than others. Putting a bit more weight on it might hurt a bit more. Putting no weight on it might hurt a little bit less. Jumping you probably can't do at that moment, right? And I don't recommend doing that. And you slowly keep moving it, keep mobilizing it, and put some weight on it. See if it's possible. If that is possible, take a few steps. If you can walk a bit, then walk. If that is unbearable, if it's too much, then at least move your ankle in the space. Like sit down and move your ankle around a bit. Don't let it completely be still. Movement is medication. Now, the first 3 days after an acute injury, you can definitely be a bit careful. You can definitely listen a bit to your body, but don't be afraid. Don't be afraid to move, especially if you don't bear any weight on it. If there's no weight on it, you can just move your joint in the ways that you want to, even if it might hurt a bit, right? Pain is not damage, as we've seen. The pain is not the danger necessarily. So move around, and then 3 days, you take it a little bit easy. 4th day, you can start to move a little bit more. Can I go for walks? Can I go for longer walks? Go for a jog eventually after a couple of weeks, for example. And just see where your body's at. See where it's at. See what you can do without forcing it and without avoiding it. There's a middle balance, and it's a little bit of trial and error to see where you're at. But most importantly, stay calm. Now, how to apply exercise for chronic pain? It's a little bit different than for acute pain. For acute pain, we would say start with mobilizing a little bit and then build up gradually and then progressively. With chronic pain, you already have been in the pain state for a while. And what's really important is that we start using graded exposure. And graded exposure is basically setting your boundary further and further and letting your body, it's okay to move. And a good way to start is by finding a way of moving the body part that hurts in a way that feels pain-free if possible. That's great and comfortable. If not, find something that is acceptable and move in that way. It could literally be just moving like this, you know? It doesn't have to be something very specific, but it could also just be something like bending your back without any weight, without any pressure, just bending your back up and down. You could also start on the floor, laying down, and then bending your back on the floor. There's a lot of exercises online that you can find. You can try them all out. As we said, there's no specific exercise that's better than another exercise. Just find what works for you, what is acceptable for you. And then challenge yourself a little bit, right? So maybe you do 10 bends one day, and then another time you do 12 bends, 13 bends, 14 bends, and then you do bending with a weight or an even heavier weight, for example, and then you just build it up. Keep in mind that flare-ups can happen and are quite common and honestly normal to happen with chronic pain, right? So you might have a period where it's going to go a little bit better, and then you have a period where it goes a little bit worse, and then a little bit better, a little bit worse. Don't lose hope. Don't lose hope. Don't lose courage. Keep on trying. Keep on challenging your body a little bit. Keep on trying to make your body feel safe. That's the most important part. For pain, make it feel safe and okay to move. Exercise for pain, especially chronic pain, is not the same as building muscle. Building muscle, you need to push yourself, challenge yourself every time. It is about making your body feel safe and in that way challenging yourself. Okay, can I feel safe in this position? Yeah. It hurts a little bit, but it's okay. Can I make myself feel safe in this position? Yeah. It hurts, but it's not that bad. And you do it, and then what you'll often find, and what I've seen with many people, for example, with back pain, especially if you had the thought or the fear that you can't round your back, it's dangerous to round your back or something like that. The experience and the euphoria of actually bending your back for the first time after you haven't done it for a long time. Like the first time, the first set, you'll bend your back, right? Standing up, you bend your back, and it will hurt. And you're a little bit afraid, you're a little bit cautious. But then you realized it hurt, but it wasn't that bad, and I'm still standing. There's nothing broken, there's nothing wrong with my back. Like I'm still moving, I'm fine. It just hurts. And then you do it a second time and you're like, it actually is okay. It hurts, but it's okay. And then your experience with the pain becomes less limiting, right? The pain might still be there, but now you can, I can move my back again. Like I've been moving around like a robot, like not bending my back, not moving my back at all. It's very liberating, and I've seen it happen time and time again with people. So I hope this video was helpful. I hope it gave insight into how exercise can help, what kind of mechanics are behind exercise and in relation to pain, and what kind of myths and nonsense that is out there about exercise, as well as hands-on interventions for pain and the idea of structures being the factor for pain, etc. We're not getting into it again, but I hope it gave some clarity on the whole situation, and I hope it gave you some reassurance. That's really what I wanted to give. Some reassurance that you can move in any way you want. There's no specific thing that is much better than another thing. Start trying things and start moving, start exercising. That is the most important part. Start trying. Movement is from everyone and for everyone. Some people like to have authority over movement and say, you don't do that, don't do that, don't do this. At the end of the day, it's your body. It's all not that special. It's all not that complex. Studies have shown time and time again that there's no better exercise than another exercise, and that we need to just keep moving. If you found this video helpful, make sure to like, comment and share it, or check out some of my other ones, like the one where I explain how pain works and the mechanics behind pain. And if you feel like you need some more direct help, I offer online one-on-one health coaching at varita.com. Thank you and have a nice day.